Hello, everyone, and welcome to NOCC's Ask the Experts program. Today, our program will discuss the recommended follow-up guidelines for ovarian cancer, also known sometimes as surveillance. We are honored to have Dr. Long-Roche join us today as our expert. She is the associate attending and associate director of the Fellowship in Gynecologic Oncology at Sloan Kettering, and takes pride in training the next generation of gynecologic oncologists. So welcome, Dr. Long.
Thank you, and thank you for having me. I always enjoy talking to my friends at NOCC and to patients and caregivers and interested people.
Yes, thank you so much. We appreciate you taking time out of your busy schedule to talk about this topic, which we get quite a few questions about, to be honest. So I think it's a good one to go over today. But for those watching, and before we get started today, I just wanted to acknowledge that we know for some, your ovarian cancer treatment never goes away. You're constantly in treatment. And we know that this can be, on and off for years and can be difficult and stressful. And we just wanted to kind of focus that on today's conversation, we will be talking about the recommended follow-up care for those who are actively who have finished active treatment. But of course, however, we know a lot of the concepts that Dr. Long will talk about today will overlap with those who are also seeing their doctor during their treatments. So let's go ahead and get started. So Dr. Long, if I understand correctly, there are no specific guidelines for follow-up care for people treated with ovarian fallopian tube cancer, but there are, of course, certain recommendations for follow-up and for monitoring patients. Is that something you can speak to us about a little bit?
Yes, of course. Since all patients have unique individual circumstances and factors surrounding their particular disease process and treatment, strict guidelines don't work well for our diverse patient population.
That's a great point.
However, there are some suggested guidelines from the Society of Gynecologic Oncology, as well as from the National Comprehensive Cancer Network, or NCCN. And in this, the backbone of patient surveillance or follow-up is an ongoing relationship with a healthcare provider, with visits, which can and should include a detailed history, meaning asking questions, a dialogue, reporting symptoms, as well as a physical exam at regular intervals. And then in addition to that, doctor's visit, we use blood tests, which many patients are familiar with, such as serum, which is a type of blood test, CA-125, and also sometimes imaging. So certain types of radiologic tests will be incorporated into a patient's follow-up. One guideline that we do have to work with from the Society of Gynecologic Oncology, as well as NCCN, is the frequency of visits. Yeah. And we monitor patients, or we visit with them more frequently in the earlier years in their remission journey. So in the first and second year, patients are seen more often, sometimes every 3 months, and that's the guidelines recommend a more frequent interval. In the third year, we space out a little bit, every 4 to 6 months. And then in year 5, it's every 6 months. And then after year 5, it's once a year. And again, the backbone of that is the dialogue and the physical exam.
Okay. And on these visits, who exactly is the physician that someone will see?
This will vary. This will vary depending on where you live, who your primary doctor was that treated your cancer, what kind of practice they practice in. So in some places, this might be your GYN oncologist who did your surgery and your chemotherapy and follows you ongoing. In other places, it might be a survivorship team, which may include other healthcare providers like nurse practitioners or physician assistants. And in some places, patients may alternate. So at Sloan Kettering, we see our patients as surgeons, and then we alternate with our gynecologic medical oncology colleagues. So we flip-flop visits. And then when patients kind of get to a certain point in their remission, they will transition over to a survivorship program.
Very helpful. Very helpful. Okay, good to know. Good to know. And so you talked a little bit about some of the frequencies of the visits. Can you talk a little bit now about what some of these goals for these follow-up visits would include, or what we're looking to accomplish with these follow-up visits?
It's a great question, and it's something that I try to talk to my patients about when they finish their treatment. So then we say, what's going to happen, over the next couple of years. And so the goals of the visit, one are of course monitoring the disease status, as doctors call it, or monitoring for any signs that the cancer may be recurring or starting to progress. And why we do that, we do that with intentional goals of identifying any cancer recurrence in a timely enough fashion to offer effective treatment for that. So we want to find it and then treat it. And so for different patients, that may look differently depending on what treatment options they have. And secondly, and equally as important, is we want to address any survivorship issues. So having had cancer and having had cancer treatment can result in side effects and changes in people's bodies and mindsets that need to be addressed over time. So things like physical side effects from chemotherapy and surgery, sexual function, and menopausal symptoms for many patients. And then other things that may result from those things, like bone health, or heart health, just general overall well-being. Another very important thing is that this is a good time when patients should be really talking to their doctor about genetic risks and whether the cancer diagnosis that they had might portend any other risks. And so during the surveillance time is really when can kind of sink our teeth into that and make sure that the patient is getting any other screening tests that they may need.
Oh, that's true. So any other possible genetic tests that might indicate other cancers in addition.
Yeah, or patients that are high risk for ovarian cancer may be high risk for other cancers, and they may need more frequent breast screening or colonoscopies, depending on their particular situation.
Going back, it's individualized, really, Yeah, that makes a lot of sense. Are there any things, while we're on the topic of quality of life issues and side effects, are there any things that stand out to you as a physician that patients should report that may be of concern, or just still keeping in touch with their doctors and having that ongoing conversation about how they're doing is really the key message, I guess?
I think both. I mean, I think the ongoing dialogue and feeling comfortable enough to report any symptoms is extremely important. In terms of specific symptoms, so different gynecologic cancers have different kind of warning signs or symptoms that we really need to hear about. For ovarian cancer, things that we need to know about are really any symptoms that are happening in the belly, in the abdomen, or in the pelvis. So pain in the abdomen, bloating or feeling swollen. I always ask patients, well, do you notice your pants are not fitting as well as they used to be? Any changes in appetite or bowel habits, bladder function, pain with intercourse, which some of these symptoms are also symptoms of cancer treatment, so it can be hard. Yeah. Patients frequently during the surveillance period will find that every little symptom is scary, and that is normal. It is normal for people to have a heightened sense of concern when they have any new symptom. And so what we usually tell our patients is that if you have a symptom and that symptom comes and goes, and you could maybe blame it on something else, like you had a big meal to eat and now you feel bloated and the next day you feel okay, that's probably nothing to worry about. But if you have a symptom that sticks around, doesn't go away, and you can't blame on something else, and it sticks around for maybe a week or 2 weeks, that's when you really need to call your doctor.
Great.
Other things like bleeding from the vagina or from the rectum, vomiting, kind of, I think, are pretty obvious warning signs to most of our survivors.
Yeah. And one of the other questions I wanted to ask when speaking about having these follow-up visits and planning, for your futures, can you talk a little bit about survivorship care plans in the field of ovarian cancer? I came from the breast cancer world, and they were very common. And I don't know how common they are now in the ovarian cancer field. Is that something that you as a physician put together for your patients, or is that something that you feel that's becoming more of a common thing to do, the survivorship care?
I think that the gynecologic cancer community is not yet gotten as comfortable with that as our
Yeah.
breast medicine colleagues are. Sorry. And so I think that we do put together survivorship plans, but I don't think we're as good about writing it down, although we are moving towards that. So
Yes.
we have, and I think many institutions have this various survivorship tools where patients will kind of receive kind of the plan over the next year. But I think with ovarian cancer, it's just so individualized that it really is hard to make a one-size-fits-all approach.
That's true. That's true. Well, thank you. For the recommendations that you're speaking about, do these apply, going back to the individualized approach, do these same recommendations apply to all types of ovarian cancer, or are there certain recommendations that might be for some types and some for others?
Yeah, so there are, ovarian cancer is not just one disease.
Right.
There are many different subtypes of ovarian cancer with many different kind of levels of need for close follow-up. So we do know that there are some types of ovarian cancer which have a higher chance of recurring, other types which have a lower chance of recurring. And so we really do base how frequently we run tests, mostly with regard to imaging tests or radiologic tests based on those things. So for some patients who have a very low risk type of ovarian cancer, we may not do any CT scans. And for another patient that might be a higher risk situation, imaging like CT may be incorporated into their care. For some types of ovarian cancer, markers like CA-125 are completely useless. So, and that applies to a lot of our premenopausal patients who've had ovarian cancer and may have the rarer subtypes. They need different kinds of blood tests monitored. So it really is individualized. And these are questions that anyone can ask their GYN oncologist to get clarity on their own diagnosis.
On their own, yeah, absolutely. Good. Kind of going into a little bit deeper of a question here is, I think that we hear sometimes some confusion around the difference between a maintenance therapy or a maintenance therapy drug and follow-up care. Can you see where that confusion is? Can you kind of talk to us about some of the differences? That'd be great.
So surveillance is a very broad term. So we can have patients who have completed their therapy, are not getting any cancer therapy, and are in remission and go into a surveillance period. But surveillance can also be used to monitor someone who has disease and we're monitoring for any progression of that disease. And so surveillance is a very broad term. When we as gynecologic oncologists are talking about maintenance therapy, we are actually talking about treatment. So a medical treatment that is being given to the patient, prescribed either by a gynecologic or a medical oncologist to decrease the chance that there will be a recurrence, or in some settings to decrease the chance that there will be growth of the cancer. Two common therapies that ovarian cancer patients may receive for maintenance are a PARP inhibitor therapy, which is a drug that is most effective for patients with genetic mutations who have completed their upfront therapy, but can be used in other situations. And another drug called bevacizumab, which is an infused drug, which can be delivered every few weeks. Other types of patients that have more rarer subtypes may take different kinds of oral maintenance therapy, like anti-hormone therapy, such as an aromatase inhibitor. But again, totally different than kind of the surveillance, us watching and caring for the patient after treatment is completed.
Right. So maintenance therapy is really still a treatment given for those reasons that you just mentioned versus sitting and waiting. And okay. Thank you for that. There is also a lot of information circulating through the news about different tests and specific blood tests that can tell you if you have ovarian cancer. Have your blood drawn. We can tell you your risk for getting ovarian cancer. Can you speak to some of those? Because I think we also get a lot of confusion about should I go get this test to see if I'm at risk, or should I go get this test to see if I have cancer? And just would love to get your input on that and kind of set the story there.
Yeah, I think no one would love an easy test to answer these hard questions more than me and my patients. So, and my colleagues. So I think that we are desperately looking for a test like that proves effective in making people live longer and live better. And I think that we just haven't had any evidence yet that one of those tests is going to fulfill that bill. So there's a lot of companies out there that are trying, just like we are as scientists, and I do a lot of research exactly in this space of early detection and detecting recurrences. There's a lot of people working very hard to develop these tests, and some of these tests make it to the market. So they make it to a commercially available space, early in their course, and they haven't necessarily been proven to find anything earlier or better. So I have all the hope in the world that one day we'll get one. But I think right now, many of those tests are here, but just have not shown us yet. And ovarian cancer tends to be a very difficult disease to find early with a blood test. And that's because what we know about ovarian cancer is that it spreads on the surfaces of the abdomen. And patients know this because they know the fluid symptoms and the symptoms that come from the disease, but it's not necessarily a cancer that commonly spreads through the bloodstream. So finding a marker in the blood is generally only something that we can easily do when the cancer is already quite advanced. So what we're really looking for is that magic test that will somehow find it when it's very early. And to my knowledge, we don't have that yet.
Well, let's keep our fingers crossed.
Yeah, we're working on it very hard.
Right. That's awesome. Yes, we are. Yes, you are. Okay. And so another question would be about circulating tumor cells. Can you speak to what these are, and if this is something that is monitored for patients?
Yeah, so there's a couple different concepts that many people are studying right now, and at Sloan Kettering we're studying all these things as well. So circulating tumor cells is one of them, and then there's another test that's very similar called cell-free DNA, or tumor DNA that is in the bloodstream. And many people know about these tests because they're kind of similar to the tests that pregnant people get when they get a blood test, and nowadays you can find out the sex of the baby via a blood test. Well, we're trying to use similar technology to see if we can find pieces of cancer DNA that are in the bloodstream. It goes back to what I mentioned about ovarian cancer being a surface malignancy. So because it's a surface malignancy, those blood tests have not yet been that silver bullet that we're looking for. So we may find fragments of the cancer DNA in the bloodstream, but we are unfortunately having a harder time finding that when the cancer is very early, which is when we really need it. And I think the concept of finding a cancer very early in the recurrent setting might shed some light on how we can find it earlier in the before it's ever diagnosed setting. So these are questions that the scientists and myself are trying to answer.
Awesome. Interesting. Thank you for touching on that. And then one of the last questions that we had that we wanted to ask you was, what do you say to those who wish for more testing and for more monitoring? I can understand the stress and the, that surrounds this, especially for those that are maybe at a certain year mark and are only going maybe once a year. I know that can be worrisome because, that they feel like they're not being as closely monitored as they should. What would you say to that individual? Or
Yeah, I think that it's very understandable. And we always talk about how some of the hardest things we do are de-escalate care. So when we do less, it's harder. It's actually easier for all of us to do more. But I try to talk to patients about what their real motivation is for wanting those extra tests. Is it that they really think that that something needs to be evaluated, in which case maybe there needs to be a discussion about why that is. Are they having a symptom? Are they not comfortable with something? Do they not understand some aspect? And maybe for some patients, getting extra blood tests is okay. But for many patients, it really is just to calm their anxiety about their disease process. And in those situations, I try to help patients find other ways to do that more effectively than CAT scans and visits, which we know at a certain time point really should be de-escalated. So many patients find that exercise and taking control of their life in other ways, like healthy diet and yoga, meditation, prayer, working with an integrative medicine doctor, all of those things can kind of help them cope with some of their fears about seeing us less.
Yeah. Well, thank you for that. Yeah. I see some questions coming in through our live chat who are asking individual specific questions of, I've been off this therapy for this long. What should I do? And I have this type of ovarian cancer. What should I do here? And I know that going back to what you said earlier, Dr. Long, was that everything is just so individualized, and that we would really encourage you to speak to your physicians. And that's one of the other questions that came through is, can I ask my physician for a care plan or a follow-up care plan once I've finished treatment? Yeah.
They may not have a pre-printed template to make one with you, but I mean, we often break out pen and paper in the clinic to write things down. And I think that that's a very good question. And I think that you can just explain to your doctor, it would really help for me to see kind of what I can expect over the next few years. Can we write down a basic framework for what that is and what our goals will be at each visit? And I think that's a very helpful conversation.
Right. Another question is, what other blood tests besides CA-125, which I know you mentioned earlier, can be helpful, cannot be helpful? What other blood tests are standardly or done as a standard, if there are any?
Yeah. Different institutions have different practices with this. HE4 is another blood test that we know can be used in the same way as CA-125. However, it's much less commonly used, and not all institutions or labs have the capability to run it. What we know about these blood tests is that they are just one clue in kind of the bigger picture. Sure. So, we take those values along with all of the other information that we gain in a clinical visit or with imaging. And so at this time, we don't have any other blood tests beyond CA-125 and HE4 for most patients. Now, for other patients, there are other tumor markers like AFP or inhibins that might be specific to their cancer. And there, the list goes on. Certainly other tests that are very important, which people may not think about in surveillance, are those genetic tests, because if people have a genetic mutation, it can completely change their survivorship plan. Okay. All right.
Thank you. Another question that we have coming through that I think is a good one is, does the chance for recurrence have to do with the stage of the ovarian cancer?
It does. So with any ovarian cancer or really any cancer at all, there is always a chance of recurrence. So unfortunately, I tell patients there's nothing we can do to eliminate the risk of recurrence. Certainly, the higher the stage of the ovarian cancer, the higher the risk of recurrence. So we know that stage 1 cancers, which are very rare in ovarian cancer, will have a lower rate of recurrence than cancers that have already spread. So that's an excellent question, and that's why we monitor our advanced stage patients a little closer sometimes.
A little closer sometimes, yeah, that makes sense. I also see some other comments coming in and some other questions coming in about just that, going back to that fear of recurrence. It's always such a heavy topic, right? And such a heavy thing to think about and to go through. And so I just wanted to remind everyone too, that, NOCC is here for you, and we have wonderful support groups available. So feel free to please go onto our website. And if there's a support group that stands out to you, feel free to join one of those, because we're all in this together. We know it's hard to sometimes just sit and wait, but that is a heavy, heavy part of having this disease. So just wanted to know that we're there for you. One of the other questions that came through, let's see here, for a longer term patient, someone who's been out of active treatment for quite a while, how can you keep your physician's attention fresh? That's the question. So that's an interesting question. So it's that ongoing communication, right?
I think that it's a very good question. I don't know. Sometimes I have a hard time keeping my own attention fresh. So no, I'm joking. It's a very good question, and I think that, you know, over time, it is easy for conversations to deviate from kind of the core why patients are there. So I think as patients, writing things down is very helpful, and keeping kind of, you know, making a list of what are the top 3 things that you want to make sure you get discussed with your doctor, and when you go in, make sure that those are the 3 things that you discuss, because it can happen that you can kind of get off on a tangent talking about something that may not be the main reason you came in, and then you spend the whole time talking about something else, and then the patient leaves and they realize they didn't get their main point across. The doctor got distracted with some other symptom that wasn't important to them or that they weren't worried about, and so I think writing things down is helpful. And then when you come in, just say, these are the 3 things I want to talk about. Can we make sure that we talk about these? And your doctor may hear you and think immediately, well, I'm not worried about those. I actually want to ask about this other thing you mentioned on the side. And so it does need to be a back and forth.
Okay.
The other thing is, I think that involving other types of providers into one's care is very helpful. Pelvic floor physical therapists, sexual medicine practitioners, survivorship teams, your general GYN. So if you're finding that your relationship with your oncologist many years out is not fulfilling your needs, it does take a village to take care of people for a lifetime after cancer.
Yeah, absolutely. Team effort. That's right. That's right. And because we've gotten this question quite a few times, we have a lot of questions today. It's great. Is people are wanting to know what the exact schedule for visits and follow-up should be. So is there somewhere that we can refer people to go and take a look at what the actual schedule should be?
Yeah.
Okay.
So the places where we kind of take our guidance from. So the National Comprehensive Cancer Network, or NCCN, has guidelines that they have actually published for both surveillance of cancers, but also for treatment. And so for any patient who is undergoing treatment and wants to know, did I get guideline-based treatment? NCCN is a great resource. And experts, so my colleagues and myself all contribute to these guidelines. So it really is something that we follow.
You just go into and type in NCCN patient guidelines.
If you go into NCCN, you may have to make an account to get to the guidelines, but it's free and should be accessible to everyone. The Society of Gynecologic Oncology is also really a place that we take our guidance from, and where our experts convene to make these guidelines. They publish frequent updates on their surveillance guidelines for patients with cancer. And many organizations like NOCC will be able to link you with these resources if they're hard to find.
Yes. Yes, if you go on to ovarian.org, onto our resources page, you will see that we do link you to the NCCN guidelines for patients for treatment. But like Dr. Long said, they also have guidelines for surveillance.
Yeah, and they're in the same PDF. Actually.
They're in the same PDF.
They're in the same PDF. It's a long PDF, but they're in there. Yes, and the other thing is that your doctor's institution or your doctor may have printed guidelines. We at Sloan Kettering have a very specific set of guidelines that we follow. And we're always happy to share those with patients.
Awesome. Well, this has been it went by fast, great discussion today. Thank you, Dr. Long. We really appreciate your time, your expertise, everything that you do for NOCC and for your patients. Thank you again for joining us today, and we will see everyone next time. Thank you.
Thank you for having me.